Welcome everybody to this lunchtime symposium. We're going to make it fun and interactive, so make sure you've got your iPads out, or we'll come around with our microphones to make sure everyone gets a say. We've got a pretty fascinating 90 minutes ahead of us, and I'm here with Dr. Tabata, who's just got to practice down the road, 5 minutes away. So thanks for joining us.
Yeah, sure.
But we're going to cover a lot of very, very fascinating topics in 2026. We're going to talk about whether carotid is ready for prime time. We're going to talk about how to have individualized deployment depth to minimize, our pacing rates, which are now nice and low, and we can get it even further. Then we're going to talk about valve-in-valve. And the topic of the hot topic that we don't want to hear about is how explants are going. What are the surgeons seeing? What techniques are they using? And everyone talks about a tsunami, and we are in Japan, but we haven't seen it. But maybe it is coming. So that's the agenda in front of us. We've got lots of learning objectives that we'll get to. But without further ado, I think it is. I'll invite my good friend Guy to come and talk to us, not about how to get coronary re-access, but how to set up a carotid access program.
Thank you, Matti, Minoru. Hello, everybody. I hope you're enjoying your bento. So we're going to talk about the carotid approach. Is this our first alternative access? Question mark. It is for us. It became for us our alternative access of choice, I would say in the last 5 years, and it's after switching to carotid, I don't want to go back to any other alternative access. So that's, I think, a very strong statement. We do a high volume of Evolut cases, and all of our alternative access, as long as doable, the first option is carotid. So I'm going to discuss the next 10 minutes or so how we implemented that in our center. So obviously, transcarotid access is reserved for non-viable transfemoral access. Today we try to push transfemoral access and doing sometimes lithotripsy, but more and more, I think we became so comfortable with carotid access that when we have a very challenging, transfemoral access that we would consider like lithotripsy and other maneuvers in very frail patients, we decided to just switch to carotid as we became extremely comfortable, and the outcomes have been really outstanding, right? So whenever you have the desire to avoid, obviously, the morbidity and of the intrathoracic accesses, there are some potential contraindications, and they're not absolute contraindications. The greater than 50% contralateral stenosis is one of them. We have done, obviously, patients that have greater than 50% contralateral stenosis, so it's not an absolute contraindication. Patients who have had prior instrumentation in the carotid artery, that might be a little trickier. And obviously, if there is a contralateral carotid occlusion, that would be a problem for obvious reasons. Another important aspect of this is that whenever patients are being screened for that, we have to make sure that actually the CT scan extends up to the mandible of the patient. In the beginning of our experience, we've had some CT scans that we couldn't see the carotid artery all the way through, and therefore this is important. It seems to be a pretty basic thing, but it is important. We do carotid ultrasound for all of our patients, and I'd like to hear later from my colleagues in the panel if they do that as well. Being careful with calcium as well as soft plaque. So we analyze very carefully the carotid artery where we're going to get access. We do not do routine assessment of the patency of the circle of Willis, and this is the majority of the centers, folks that do a lot of carotid accesses. I don't know, people are not doing this, so we do not do it routinely at all. And one thing that is important also to emphasize is that the carotid artery is much less prone to calcification and tortuosity compared, for example, with the subclavian artery that used to be our alternative access of choice before we switched to carotid. And this is just an example. This is the same patients looking at a very calcified, subclavian artery, as the carotid has minimum calcification. And as you can see, it's a straight shot to the heart, making it very, very easy to perform the procedure overall. I apologize, the quality of this picture is not great, and obviously the setup of the room, it varies from center to center, right? But we tend to stand always on the right side of the patient, and even if we're doing left carotid, which is the majority of the cases that we do, for us, that's how it works better, and we have always someone on the left-hand side of the patient to stabilize the sheath that we're using if we're doing pre-dilatation, or to help control whenever there's a bleeding or anything like that. So there's always somebody, usually a surgical assistant on the left-hand side of the patient. But that's pretty much the setup of the room. It is, you get a little more radiation, obviously, but it's still it's a very good setup, and we have good control, and we became very comfortable with that. So the proximal common carotid artery is exposed via a small incision, really normally around 2 centimeters above the left clavicle. Careful dissection, being careful with the vagus nerve, and the vascular clamps are put proximally and distally in order to insert the 6 French sheath, which is the first one. We do not do cerebral monitoring anymore. In the beginning of our experience, we were doing for every case, and we realized that we were not actually changing what we're doing. Even if there was a drop in the SAT, we just needed to complete the case, so we're not doing it anymore. Routinely, we do not perform cerebral monitoring. We try to keep the systolic blood pressure above 140. That's an important thing to do. So we try to keep the patients a little more hypertensive. And the large bore sheath is only needed if you're going to predilate. If you're not going to predilate, you don't even need to put a large bore sheath. Just go with the inline sheath. You go with the 6 French. Once you cross the valve and you put a stiff wire, then you just go with the inline sheath. You do not need to have any large bore sheath to perform this procedure. So this is just a very short video of the carotid artery exposed. Then we're going to do, just use a regular needle. Then we're going to puncture. Then insert a short wire. Then the 6 French is going to go over that wire. I'm going to pass a little bit faster here. So the 6 French goes over that. Then we're going to cross the valve as we normally do. And then after we insert the stiff wire, which is already in place, as you can see, then we go with the valve, just the inline sheath. You don't have to have a large bore sheath. And it's the fact that it's mostly straight is makes it extremely easy. And then after the procedure, we remove everything and then just a surgical suture. This is just an example of a cusp overlap deployment here in a carotid case. And this, even in cases like this one, you can see that the left carotid is actually, both carotids are very tortuous, as you can see in this case. Nowadays, with the steady wire that Medtronic has, which is a very stiff wire that provides a lot of control in situations of tortuosity, both for transfemoral as well as for carotids that are tortuous, we have been using the steady wire very consistently in like 90% of our cases, and it works extremely well. So I would strongly encourage you to attempt to use this wire. It works very, very well, and it makes it much easier to deal with tortuosity such as this one you can see in this case. This is the right carotid of this patient, also quite tortuous. But you're going to see this is the left. We decided to go left in this case specifically. And you're going to see with the steady wire how straight the artery became, and it's very easy to insert the valve, and the inline sheath goes. It's extremely easy to, and this was, in this case, was a 34 valve. So what is the data behind carotid access, right? So compared with subclavian access, I think there's good data showing that there is less stroke risk. This was one of my concerns when we started doing carotid. I had this fear, this was years ago, of increasing stroke rates, but I think for now there's a lot of evidence showing that the stroke rates with carotid is actually less than it is with subclavian cases. So that's very much reassuring. And there's plenty of data showing that obviously carotid access is better than any like the direct aortic or any intrathoracic access overall. And even when you compare carotid access with transfemoral access, you can see that stroke rates are comparable. So the outcomes overall with carotid access are very similar to the ones of transfemoral access, and therefore we started using this very, very consistently. Our experience at UH, we've done more than 60, but we have 60 patients with 30-day follow-up. We haven't had any mortality and only one stroke, and this stroke was related due to hypotension. This patient had a lot of complications. But in addition, the other thing from a workflow perspective is the fact that these patients go to the ICU already extubated, and they still go home next day. So we have the policy of sending patients home next day until proven otherwise, and most of these patients can still go home next day. So that is very also important for our workflow in general. So just to finalize here, so transcarotid access for TAVR is associated with very high success rate and excellent clinical outcomes. The increased utilization in the USA with lower stroke rates compared with transsubclavian access. Repetition, obviously, it's important. When we started, we needed to quite understand even like the setup of the room and everything, but after that, we got very comfortable and ultimately we're able to deliver great outcomes. And I strongly encourage you now that carotid access is approved in Japan to start considering that as an alternative access of choice. Thank you for your attention.
Wow. Guy, great presentation. It's great to see how you've grown this program to have 60 plus cases, and now it's your first access. Can I just get a show of hands? Who here has done transcarotid?
Oh, many.
No, not that many. Who here is like Guy has completely changed as their primary access? Wow, it's two of you. Two of you, that's sensational. Yeah. What have been the barriers, I guess, from going back to general anesthetic, changing the room positioning, getting everyone used to a new technique, I guess?
Yeah, so to be clear, right, our subclavian cases, we were doing still subclavian with the section. We were not doing percutaneous subclavian cases. I don't see much value in percutaneous subclavian. That's a different discussion. But we didn't actually go back to the general anesthesia because we were doing general anesthesia for the subclavian case. What I would say to you, Matti, is that when we were doing subclavian, if the patient had a femoral access that we knew we were going to have to work hard on it, but likely we would be able to go, then we said, let's try to go transfemoral. If it doesn't work, we go subclavian. For carotid, it's the other way around. Let's go carotid. I mean, I'm not going to fight this transfemoral access that is hard and in a frail patient, those like small, ladies, bleeders. So we just decided to go carotid. It works extremely well. So I think that has changed substantially for us.
So yeah, thank you for sharing your detailed procedures and experience with us. This is a hot topic because transcarotid access for Evolut has been just approved in Japan like a few months ago. And then I think Evolut platform is well designed, actually better designed for the transcarotid approach for the other one. So because it doesn't have like expanding sheaths, which could injure the carotid intima, and also it doesn't require the repositioning the valve on the balloon in the short ascending aorta, which I always feel stressed. What do you think about the like a design of a delivery system of Evolut for carotid access?
That's very, very good question. So the fact that you can go with the inline, as you highlight, you don't have to put a sheath, right? So that's a big advantage. So in case you're going to pre-deal, obviously, then you're going to put the sheath and exchange as you normally do. But the fact that you can use the inline sheath to go from a 6 French all the way to the inline, it's a great thing, right? So in addition, there's one thing that is important though, is when you're going to recapture the nose cone, it's a little bit of a different process because rather than recapturing the way we normally do, you have to use those two buttons in the back and pull the nose cone very gently. You won't have the ability to do this. So then you pull it gently, and what we do, we remove everything. We pull the wire and we remove everything after we do the TE probe is there. If we like it, we're going to remove everything. We don't keep the wire or anything in and just remove everything as a unit. Everything comes out. We retrieve the wire and then nose cone and remove everything as a unit.
All right, thank you. And one more question about the preoperative screening. So you mentioned MRA, brain MRA is not necessary. Do you have any rationale you don't need? I mean, I would avoid a carotid access if I don't see the good communication between the right and left and anterior or the posterior side.
Yeah, that's a good question. In the beginning, we started doing, well, of course, in the beginning of the experience, we started doing cerebral monitoring, doing that. But then I started talking to people that they were doing carotid access, and actually nobody is doing this anymore. So then we stopped doing because we don't do it. I mean, we just do the regular screening in terms of we doing the carotid ultrasound, as I said, and that 50% marker of, if the contralateral carotid is greater than 50%, we don't necessarily respect that precisely at 50, right? That's going to depend on the patient, right? If the patient has no other good access, and if 70%, we may still like to go carotid, right?
Yeah.
So, but we don't do the MRI, and as I said, most centers that do a lot of carotid cases, they're not doing it either.
How do you think that uptake is going to be? You know, we've got the international panel, we've got Japan, we've got US, we've got Australia here represented. Where is this going to land in Sydney?
So thankfully alternate access is becoming less and less frequent with the great delivery profile of most of the systems which we have these days, and particularly the Evolut FX+. The beauty as an interventional cardiologist of transcarotid TAVI is that it's a direct shot. It's a very stable deployment system, and someone else gets the access and closes while you're getting coffee. Like it's a really good procedure from that point of view. And I too shared the concerns about the stroke risk early on, but certainly that hasn't been the case. And we predominantly did transaxillary TAVI to begin with, but we're switching to transcarotid now. I guess in terms of getting used to the setup, one of the things that we found that we learned from our colleagues just north of us were that sometimes switching the patient so they're upside down, so you still stand on the right-hand side when you're doing left carotids, can be actually quite useful in terms of workflow.
Okay, so our practice is a little bit different. First of all, our table extension is on the left side, not the right side. So it's a little bit different. I agree. We don't do any cerebral monitoring. We don't assess Circle Willis or anything preoperatively. But our choice for alternative access is actually suprasternal transinnominate. That's a Michigan approach. And then we mark along the skin crease 2 centimeters. 1 month later, patients ask, where is my incision? It's completely gone. And then innominated access, it's a much bigger caliber, no ischemia time at all. You can put the 22 Gore sheath easily for most of patients, even though we are using 34 Evolut size. So again, it's controversial. And then I just grew up with a suprasternal, training pathway, and it's very unique. But yeah, I think our outcomes are pretty much similar. It's very good outcomes. My cardiology colleagues love it, patients love it, so it's a great approach, but yeah.
So what would be the second alternative approach if the innominator artery is not feasible? Do you choose a carotid or axillary?
Yeah, so yes, my second choice is the left carotid.
Oh, okay.
Yeah, the other day actually, interestingly, we had a leaflet modification case using shortcut, actually 2 leaflet modification from alternative access. And then my choice is a transinnominator. However, picardia people said, do left carotid, otherwise it's not gonna work. So anyway, I think we flexibly change the approach, but I think it's 80% of time, ours is a suprasternal transinnominate.
Interesting. Okay. So Dr. Kanzen, so we
Thank
have a
you.
panelist from
Yes,
Kyoto, Dr. Kanzen.
I'm from Japan, and thank you very much for your great presentation. And I ask you the one point. You said that you insert core valve after extracting the 6 branches. So does it mean that you don't use pre-BAV, right?
No, when we do pre-BAV, and we do for most of our cases, but in cases that we elect not to do pre-BAV, then we move from the 6 French to the inline sheath. And obviously, even if we're doing 34 valves, then we still put a 14 French sheath for pre-BAV, because then you can just open with the blade, you can open a little more to go with the 34 inline.
And I want to ask you a question about the timing of the clamping of the carotid artery, because in Japan, some physicians don't do the carotid artery clamping during the TAVR. So what do you think? Is it correct or not? I think I should clamp the carotid during the TAVR, so some physicians don't do that. What do you think?
We do. We clamp the carotid artery. We do. Yes.
The timing, when do?
Well, right when we get access, then we clamp it, right? That's why you have to move. This is important that you move, in a good pace, right? Because obviously the carotid artery is clamped. To try to move in a good pace. In fact, when we do carotid arteries, our fellows, they don't have it. We do mostly like the attendings, we do the case, the fellows help, but because we need to move in a good pace, right? Because we have that, of course, in mind, that the carotid is clamped, yes. But we do clamp, yeah.
We've got a great question from the audience about just your pre and post dilation. Can you talk us through what you're using if you need to pre-dilate with someone needs a sheath size of only 9, 10, and then what do you do with the post-dilatation? What sheath do you pull back in, and does that impact your outcomes in any way?
Yeah, so if we need to post-dilate, then we're gonna put, usually we put a 14 French sheath back in, and then we will post-dilate them based on the anatomy of the patient, of course, respecting the size of the waist of the valve that we used, and then that's what we do basically. And for pre-dilatation, as I mentioned, we use 14 French normally because we use true dilatation balloons, and then we usually go 14. We go in the center and 14.
Yeah, so it's not a problem. Can I ask you a question? Because I'm worried about the brain, right? And as you know, we've had lots of studies with MRIs that you get 90+% of embolic events with transfemoral. Do you think there'd be a value in comparing a transfemoral versus transcarotid with MRIs pre and post?
Yeah. Maybe. I mean, as I said, Matti, one of my greatest concerns in starting doing carotid was stroke, right? But I mean, it's clear, the data is clear that the stroke rates are actually lower than transsubclavian, and it's as good as transfemoral. So it is.
Yeah, look, and if you're getting less hits to the brain, asymptomatic, that would be a game changer. That would get people to completely change.
Maybe.
Because at the moment it'd be hard to make it. I'm talking from Australia point of view. We have a lot of access issues to cath lab and anaesthetics and vascular surgeons or cardiothoracic surgeons, and to try to get them to close while you have coffee, it's a tough sell. So I'm not sure if they're going to be that interested in doing all of the cases, but Vivek's got better pull than me. But, well, look, I think we're running on time. So this great Guy, let's give him a big clap. Look, we're going to move into TAV-in-SAV, some key considerations, as we're seeing a lot of these.
And I've got Dr. Sakamoto.
Oh, Dr. Sakamoto, yeah, sorry. Oh, how are you, Dr. Sakamoto? It's good to see you. And, mate, we're very, very excited to hear about your individualized deployment depth based on your ICE strategy. So we're very much looking forward to hearing from you.
Okay, thank you for the introduction. So my name is Dr. Sakamoto from Saisei Kakumoto Hospital. So I would like to appreciate this opportunity to speak with you. So my talk today is title is Pacing and ICE. ICE is intracarotid echocardiography, ICE strategies for successful implant. This is my disclosures. Okay, so first topic is pacing matter. So in my institute, we don't use RV pacing routinely. Instead of that, we use LV wire pacing. So the reason why we don't use RV pacing, that is RV wall is more fragile than we thought, like this. This is an ablation catheter, is visible from the outside. So actually, it's a previous report in the early days of TAVI from Milan, Italy, so Dr. Colombo's team. So they report the incidence of the cardiac effusion tamponade in their institute. At that time, tamponade rate is 4.4%, and the reasons of the tamponade is more than half is RV rupture due to pacemaker lead. That is a reason why we don't use RV lead routinely. Actually, we experienced 2 cases tamponade due to pacemaker previously. So this is our system for LV wire pacing. We use high output EP equipment for as a pacer. So during pacing, the ECG wave looks like a unipolar pacemaker, like this. So what is the best guide wire for LV wire pacing? So I believe the Medtronic confida wire is good for this, but the as well as the SAPI wire is good for LV wire pacing, because the SAPI is designed to specific to the LV wire pacing. So this is a previous our data. So confida is less pacing threshold by according to the Safari. So this is a preliminary data, but the SABI is as comparable confida wire. So we use these 2 wires during LV TAVI procedures. So in case of the AV block, unfortunately, the AV block occurs. So what can we do? So this is our method in the ad hoc rescue RV pacing. So in the high-risk case of the AV block, we usually use ICE catheter like this from the neck Cs. So after the AV block occurs, so we don't use ICE catheter anymore, so we can remove the ICE catheter. So then we insert the guide wire and the 5 French Cs into the 9 French Cs. And we place the pacemaker like this. So we call this method the 5-in-9 method. So this is really useful the rescue emergent RV pacing. So after the RV pacing started, we can remove the LV wire. So final topic of regarding to the pacing is a guide wire pacing inserted into the SVC. So this is our new method. So conventional LV wire pacing, we use subcutaneous needle lead like this. But in our new method, we use a guide wire. So we inserted the venous teeth from groin for this is emergent ECMO cases. So this is a long cis. So the cis kit has this long guide wire, spring guide wire. So we inserted the guide wire into the venous cis into the SVC like this. So we can pace between the SVC lead and the LV lead. So in this method, the pacing threshold is much lower than the regular subcutaneous lead. So this method is better for pacing, and the patient don't feel twitching due to the subcutaneous lead. So my next topic is intracardiac echocardiography during TAVI. So why do we use TAVI do we use eyes in our procedure? Because the major reason is eyes is covered in medical insurance in Japan. But we don't use eyes in every case, but the selected case. So one is the high risk of AV block, as I told you previously. So this is a Kendra's famous paper. The right bundle branch block and the deeper implant depth is a risk for permanent pacemaker implantation. So they propose a four-step cusp-over technique method. So that can reduce the pacemaker implantation rate, so 61%. So the method is a four-step cusp-over technique like this. So they use stiff wire on the cusp overlap angle during implantation. And this method, the pacemaker rate reduced from 98% to 5.8%. But in this method, the implant depth is fixed at 3 millimeters. So, but to avoid the AV block, the true concept is we have to implant the Evolut within the membrane septum length. So this is also a famous paper from New York. So in this method, if we implant the Evolut within the membrane septum length, the new pacemaker rate is quite low. So but the 3 millimeter depth is good for shallow enough for Western people. We Japanese, membrane septum length is shorter than them. So we need to implant more shallow, and we take a risk of the pop-up during implantation. So to avoid pacemaker risk and to avoid pop-up risk, we use eyes. So this is a paper from Kokura Memorial Hospital. Dr. Isizu wrote this paper. So even in the short MS cases, so with use of eyes, we can reduce the pacemaker rate 2.6%. So during the eyes examination, we can check the depth of Evolut like this. So we implant the Evolut as deep as possible within the length of membrane septum. So we can avoid the pacemaker implantation and also the pop-up of the Evolut. So the final topics of my presentation is a rapid final deployment of Evolut. So recently, the Japanese operators, this method is really become popular. So, but the some operators, the pacing rate is 150, or some operators 180 is good. So the optimal pacing rate is not unclear. So to check this optimal pacing rate during final rapid deployment, we use TAVI wire as I previously mentioned. The TAVI wire is designed for LV pacing, and also to use this wire, we can monitor the LV pressure continuously during TAVI procedures. So we can check the LV pressure anytime in the TAVI. So this is a monitor of the TAVI wire. So we can check. So this is a mean pressure gradient 74, is a really severe case. But after the Evolut implantation, so mean pressure gradation is 7. So we continuously monitor the simultaneous pressure gradient during TAVI cases. So in the Medtronic people says that at the 80% of the deployment, the valve works. But actually, we have some pressure gradient during, even at the point of 80% deployment. So this case is not so large pressure gradient, but in some cases, a great pressure gradient remains. But the pressure gradient is reduced, decreased like this, according to the pacing rate. So in this case, 180 ppm is good for final deployment because there are no pressure gradient anymore, so that we can deploy the Evolut precisely and safely. So this is a preliminary data from our institute. So Dr. Konami is collecting this data. So as you can see in this graph, the pressure gradient is decreased according to the pacing rate. So we believe that the under 20 millimeter mercury is good for final safe deployment. So 200 or 220 is good for this method, we believe. So this is my last case. Last Tuesday, we deployed this valve at the pacing rate to 220. So the Evolut is really stable during final deployment. So we call this method the minimum rapid pacing rate with the least pressure gradient. So that is my this is end of my talk. Thank you for your attention.
Wow, what a tour de force. That was sensational. So many concepts there that we're going to latch onto because we've got a lot to discuss here. I am fascinated with your ICE-guided deployment. Can you talk us through the learning curve of your team and how much time it adds to the procedure?
Yeah, some institutes, the ICE operator is also TAVI operator. But in my institute, the ICE catheter is manipulated by the echo people. So they really nicely make a good image by the eyes. So I think the learning curve is not so long. It's really one or two times is okay for training.
We don't have reimbursement for ICE, so it's unfortunately that we may not get there soon.
Right. Yeah. Can I make a quick comment as a surgeon? Well, I think that the use of ice for Evolut or any self-expanding valve is a game changer. So although I do a TAVR, I'm a surgeon, so I usually stand at the server side when we debate the server versus TAVR. I was like, oh, in surgery we can directly visualize the membranous septum, and we can eliminate the pacemaker. And actual pacemaker rate is nearly 0 in my practice. But after we started using ice, actually, we see a mass very clearly, so we also can visualize membranous septum very clearly in TAVR, and it reduces pacemaker rate significantly. I think the use of ice should be the part of the standard procedure.
I have a question. So how often do you, because you can know the length of the membranous septum by the CT prior, right? So how often, and when you put in cusp overlap, theoretically you have a good understanding of the depth of the valve, right?
Yes.
How often do you change your management of the case, meaning you take a picture and you think you're at 3 millimeters or 2, but looking at the fluoroscopy versus with the image that you obtain from ice?
Yeah, actually, the three-dimensional data is useful for us. So when the parallax is small, but in many cases of the cusp overlap angle by the CT data, we have some parallax even in the cusp overlap angle. So we use a two-pigtail method because the parallax is minimized to at the site of the operation room. So we place the pigtail to LCC and RCC, and move the C-arm to the RL caudal direction, so to see the two pigtails like this. So that is a true cusp overlap angle. And we know that membrane septum length is really different from the data from ice. So ice data and the three-dimensional data is not the same most cases. So we rely on the ice data more than the three-dimensional data. Okay.
Yeah, he's right. We very often see the discrepancy between the CT finding and ice finding. Yeah, it's true.
Is there any way to rationalize the ice usage? So does ice overcall or undercall compared to CT the membranous septum length? And is there a threshold which you could perhaps say, if the membranous septum on CT is above 5 millimeters, we don't need to bother about ice, we're going to have a pretty safe implant?
Sorry?
So I was just wondering whether there was any way to, our ice catheters are not reimbursed, to work out which cases ice is most likely to be beneficial for.
MS が CT で何ミリ以下だったらとかありますか?
So yeah, as I mentioned, so we implant the Evolut so as deep as possible within the membranous septum length. So we use ice when patient ECG has a CRBB case or short membrane septum by CT. So in our practice, daily practice, the ice use is 20 or 25% of all cases.
Yeah, in our practice, we use ice if the CT shows like a MS length of 4 millimeter or less. Yeah, that's our cutoff. Yeah, but there's no evidence though. Okay. Yeah.
Can I throw out a clinical scenario? You've got a patient who's got a right bundle branch block. Right? You're concerned the membranous septum is 4, right? And you're seeing yourself landing at 3.2, right? And you're happy with that. But as it happens, they get some swelling, even the wire, they can have transient complete heart block. And they have perhaps some of that over the first 24 hours that you see on telemetry. But you're confident that where you've landed. Would you be confident to give that patient time without a pacemaker? Or, it's, even the optimized protocol, if you're having, complete heart block, you got an indication for a pacemaker even in the early stages?
Yes, the optimized protocol, the patient discharge is the next day of the procedure. But in our institute, the patient should stay in our hospital after 2 days, TAVI. So during the 2 days, of course, we monitor the ECG. So unfortunately, AV block occurred during the even with the ice procedure, but sometimes AV block occurs. But in those cases, the AV block will recover within 24 hours. So that is good for patient. So we can avoid the pacemaker implantation. So to see the patient for a longer time.
I have a question about the deployment. Let's switch the gears a little bit. So the deployment, you're showing that you pace the patient, higher rate for the final deployment between 80% and the very end, right? And I noticed that because you pace on your wire, you don't pull the wire from the apex, right?
Yes.
So that is actually the reason why we do not pace on the wire, because I feel like pulling the wire in the nose cone is a very important step to make it stable. And I also have a feeling that more important than the pacing at that point. We pace, but we pace in a much lower rate than you do. We pace like 120 just to keep the systolic around like 120, 110, 100. But we go very slow to let the nitinol expand very slowly, right? And the valve doesn't move from 80% to the end. If you see a major movement of the valve from 80% to the end, it's because you are doing something wrong in your deployment, right? Can you comment on that, please?
Okay. So because you are good TAVI operator, so that is stable implantation is possible. But during rapid pacing, so as you can see in previous my slides, the pressure gradient is very small, and the simultaneous detachment is important for that concept. And the pacing method, of course, we pull back the every wire during final deployment, but of course, not totally, but in some type of the pace guide wire, if in the LV, so we can pace that point. And so rapid pacing is also safely done, even we pull back the guide wire.
Okay, thank you, Dr. Sakamoto. All right, let's move on. So we have two more interesting topics. Both are very important for lifetime management of aortic stenosis. The first one is a TAV-in-SAV. Our speaker is Vera Kushwaha. Please, go ahead.
Thank you very much. I'll just get my slides up. Thank you very much for having me here. I'm from Prince Wales Hospital in Sydney, and I'm going to talk through TAV-in-SAV key considerations. These are my disclosures. The aims of this talk is to demonstrate or really show what we're expecting with TAV-in-SAV procedures and the burden that we're going to experience across our centres in dealing with these patients. We want to look at the procedural assessment and the planning of these procedures. We want to be able to identify risks that are specific to TAV-in-SAV procedures and then talk about strategies to minimise the risk. And then finally, look at how we're going to optimise these patients who are having their second procedure in terms of both hemodynamic results and setting them up for the future. So this is some Australian data looking at the incidence of TAVI and SAVA. On the left-hand side, you'll see that the SAVA numbers have been decreasing a little bit steadily over time with a rapid expansion of TAVI procedures in Australia from the early 2012 to 2022. On the right-hand side, these are surgical aortic valve implantations based upon age. The top line being patients under the age of 50, And the bottom two lines are patients between the ages of 70 to 79 and those above 80. And it's looking at the mechanical valve implantation incidence amongst these groups. And what we've seen over time is that the overall incidence of mechanical valve implantation in Australia has dropped from about 38% previously back in 2004 to less than 8% what we're seeing now. And that has been driven across reductions in mechanical valve implantations in all age groups. And so we've seen a great increase in the number of bioprosthetic valves that are being implanted. And what that means is we're getting bioprosthetic valves in younger patients, we're getting more bioprosthetic valves put in, and we're going to see more and more TAV-in-SAV procedures being required in the future. And I think this is the tip of the iceberg. We are expecting, this tsunami of TAV-in-SAV procedures, but we're still not seeing the full extent of TAV-in-SAV procedures yet either. This was an elegant little modelling study done by Yohei's group, which was looking at the predicted volume of both TAV-in-SAV and TAV-in-TAV procedures over the next 10 years. And they predicted, if you look at the number of SAVA and TAVA volume across Japan and the US, look at issues like valve durability, survival post-procedure, then you will realise that in conservative estimates, you're going to get an increase in the need for redo procedures in these patients between 5 and 8% over the next, 5-fold to 8-fold over the next 10 years, which is a huge burden for our treating populations. Why do these valves fail? Well, they fail for a number of reasons. We can largely divide these up into bioprosthetic valve dysfunction, which is non-structural and structural. When we talk about non-structural, we look at things like patient-prosthesis mismatch, most importantly, small valves that have gone in small anatomies, and paravalvular regurgitation. Now, these can be impacted by things such as malpositioning, valve embolization, etc. But often when we look at this group of patients, we don't see any structural change within the valve hemodynamics per se over time. Then we have structural bioprosthetic valve dysfunction, which relates to changes within the valve itself, intrinsic to the valve. So these are caused by damage to the leaflets, perhaps thrombosis, infection, inflammation, pannus formation, and they can lead to changes in the hemodynamic performance of valve over the time. Now, both these can lead to bioprosthetic valve failure, where you have then an indication for re-intervention or valve-related death. And when we look at explants, you can see that there are a whole lot of different pathologies which can cause valve failure. So on the left-hand side image, the top image is looking from the flow surface of the valve, and you can see some pannus formation and very heavy calcification and fibrosis of one of the leaflets. And that again is visible from the non-flow surface as well. In the middle panel, you can see a laceration of one of the aortic valve leaflets, a hole in the leaflet from degeneration, and then on the right-hand side is obviously endocarditis. It is sometimes difficult to tell the difference between non-structural and structural bioprosthetic valve dysfunction, and this is a patient who had a freestyle route who was sent for us for a valve-in-valve TAVI, who actually had just a paravalvular leak. So assessment of these is really important, and you really need to tease out what mechanism of failure you have so you can offer them the right treatment. There are different types of bioprosthetic valves, and it's important to know the different types in order to work out how you're going to plan for these procedures. Largely, you can break them up into stented valves, those which have externally mounted leaflets, like the trifecta and MitraFlow. They're made from the externally mounted leaflets of both of these valves are bovine pericardium. The trifecta valve is a non-fracturable valve. MitraFlow is a fracturable valve, and that's very important when we work out what to do in terms of our valve-in-valve procedures. The externally mounted leaflets, they're the ones that have the high risk of coronary obstruction because the leaflets are outside the valve frame. The internally mounted leaflets, lower risk of obstruction of coronaries, and again, There's a variety of those which are fracturable and non-fracturable. They're made from either porcine or bovine pericardium. Then we have the final group, which are the stentless valves, which often when you're doing your assessments, you'll need to do your assessments more like a conventional TAVI. And the sutureless valves, the Percival valve is a little bit unique. The sizing of these valves is quite different, and depending on the way the surgeons implanted them or whether they've been post-dilated, the size can change a lot. So you really have to be very careful in your measurements while determining this, and perhaps this is more like a TAV-in-SAV procedure rather than a TAV-in-SAV procedure for those. The pre-procedural planning CT is absolutely key. So measuring the internal diameter of the valves is incredibly important. It's good to do these yourself, even though obviously we do have the valve app, which I'll talk about soon. If you know what the index valve is, then it's good to compare what your measurements are to what we're expecting to see. You can measure the true internal diameter, you can measure the height of the stent posts, and what you really want to see is where the stent posts are in relation to the height of the coronaries. If the stent posts of your bioprosthetic valve are below the coronary ostia, then there's no real risk for coronary obstruction. If, on the other hand, the level of the posts, the coronary ostia, come off below the level of the posts, then you need to look a bit more carefully, and what you want to see is the distance from the valve to the coronary ostia. So you're looking for the VTC plane. You also want to look at the height of the STJ and also measure the distance from the valve to the STJ to work out your risk of coronary obstruction. The valve-in-valve app is king, and we all use this every day in our practice in terms of trying to work out what valve. It's very good in terms of selecting the type of valve, gives you the true size. It will tell you whether or not it's flexible or not, and also give you an indication and guidance as to which valves are going to be able to put in. Coronary obstruction is one of the most feared complications of valve-in-valve TAVI, and really this is what we want to analyse in great detail when the valve, the coronary ostia, come below the valve leaflets. And it's really when you've got a very short valve to coronary ostia distance that puts you at the highest risk with a very narrow STJ. And in those cases, you need to do something to try and protect your coronaries. Now, you can do leaflet modification procedures, which can be either balloon-based, electrocautery-based, or if you're lucky enough to have access to dedicated devices such as the shortcut device, you need to consider those. You can protect the coronaries by stent, with the use of stents, so chimney or snorkel stents. You can use balloons, and some people have indicated, they use IVUS assessments to work out whether they need to stent these procedures or not. Or, of course, redo TAVR needs to be considered as well in the very high-risk cases. What do you do in terms of the risk of coronary obstruction? Is there a difference between leaflet modification and chimney or snorkel stenting? We don't have any obvious head-to-head data, but non-randomised samples seem to show not too much difference in terms of one-year outcomes and periprocedural risks, with the exception of having a bit more AKI and PVL after chimney stenting. The next most important thing about valve-in-valve TAVR is to look at optimising the hemodynamics of the valve. So a lot of these patients that we're putting in valves into, we're seeing smaller valves failing. If you've got a small index valve, if you've got stenosis as the primary mechanism of your valve, if you've had patient prosthesis mismatch after your original surgery, all of these things are factors associated with patient prosthesis mismatch post TAV-in-SAV, which makes sense. And so we really need to work out how to best treat these patients. And here's where valve selection is key. So even from the very early data from the global registries, we're seeing a difference between balloon expandable intra-annular valves compared with supraannular valves, where we were getting much better hemodynamic profiles, particularly for the smaller valves with the supraannular valves. And so the choice of valve in these patients is very, very important. You want to implant a valve which you know you're going to have very low gradients, good hemodynamic performance to get a good outcome for the patient. There's no point doing these procedures and leaving the patient with a mean gradient of 30 immediately post-procedure. Now, what else can you do in terms of trying to achieve optimum results for these patients? Well, you want to get the most out of your valve, particularly if you're using a supraannular valve. You want to avoid a very deep position to take advantage of that supraannular position of the valve. You want to do balloon valve fracture, and I think we're doing more and more balloon valve fracture, particularly of the smaller valves. And even if you don't have a fractural valve, you should be trying to optimize the expansion of the valve that you've got in there, and your post-dilation is key. So I might just finish with a case which kind of brings all of that together in the one case. So this is a valve-in-valve case. This patient had their first index SAVA when they were 74 years old. They had a 23 millimeter mitral flow. They're not really put in anymore, but back then they were in vogue. And she was now 83 and had bioprosthetic valve stenosis. Her peak-to-peak gradient across the valve was now 4.5. Interestingly, her immediate post-gradient, 5 days after her initial SAVA, her mean gradient was 18 millimeters to mercury. So she already had some degree of patient-to-prosthesis mismatch. She was comorbid. Most impressive thing was that she had quite significant interstitial lung disease and she was moderately frail. When we look at the valve that she had, the true internal ID of this valve was only 19 millimeters based on the app, so we already know we're expecting patient-prosthesis mismatch even after if we just put a valve in because there was some degree later. So we're planning a valve-in-valve TAVR. These are the things that we need to think about: balloon expandable, self-expander, balloon valve fracture to try and minimise risk, and are the coronaries at risk? So, as with all of us, she was presented in a heart team. You can see just from the angiography alone that the coronary heights are low, very low on the left main and low on the right as well. She had a very narrow VTCs on both the left and the right. She had very shallow sinuses, and her STJ height was only 13 millimeters, so the valve posts extended up to the STJ, and the VT to STJ distance was less than 2 millimeters on both sides. So this is a patient who's got super high risk for coronary obstruction. They also have very high risk for patient-to-prosthesis mismatch. So if you're doing a procedure, you're going to be doing balloon valve fracture, you need to do something for the valve as well. So when we discussed in our heart team, we asked the surgeons to reconsider. This is the kind of patient where you might need more than one discussion. But because of her risk and frailty and her lung disease, it was decided that she was still too prohibitively high risk. And so we had to plan a strategy to try and take care of her coronary obstruction risk and give her a good performance. So our decision was to use a supraannular valve, do leaflet modification rather than stenting, because we're likely going to need to do balloon valve fracture, and if we do that with stents, then we'll likely crush the stents and it'll be quite complex. And so we needed to do leaflet modification for both the left and the right. And so one of the issues, if you're doing leaflet modification with 2 leaflets, then you can get quite profound hemodynamic compromise. So we decided to set up for a basilica for the right coronary cusp and did a cleave or unicorn procedure for the right-hand side. And the reason why we did this was we were able to set up the basilica but not cut the leaflet, then basically deliver our safari wire through the left coronary leaflet, perform our unicorn procedure and balloon dilatation, get our Evolut valve in position prior to cutting the leaflets, and that way we're able to rapidly deploy the valve. Now, despite that, she did have quite profound hemodynamic compromise, and we had to deploy the valve quite rapidly. So we ended up deeper than we would have liked to be. You can see the frame's quite constrained, so we then performed balloon valve fracture with a 22 millimeter Atlas Gold, and you can see the point where that gives. And the final result was quite good with a very wide open valve with low gradients, and we're able to access the left and right coronary arteries. So TAV-in-SAV is definitely standard of care for these procedures, and we're going to see a great increase in the number of the procedures we do. Careful procedural planning and understanding the anatomy and the initial valve characteristics are really important for performing your procedure. And we all need to have strategies to mitigate the risks, particularly for coronary obstruction. Now, thankfully, leaflet modification, certainly in our practice, occurs in less than 5% of valve-in-valve cases. One of the things that we do a lot of, though, is balloon valve fracture. And particularly we're seeing with smaller valves, we're doing this more and more routinely because that sets us up for further procedures down the track. And it's really important to choose your valve so that you've got good hemodynamic performance and it gives you all the options that you want down the track. So, thank you.
Okay, thank you very much for the informative talk. You actually covered a full spectrum of TAV-in-SAV. Appreciate it. But you didn't mention one thing. So actually, a couple of recent studies using a large database which compared TAV-in-SAV versus redo server showed short-term superiority of TAV-in-SAV, but long-term superiority of redo server. What do you think is the main reason of a poor long-term outcome of TAV-in-SAV?
So I think one of the issues with the long-term outcomes is, even if you look at relatively contemporary databases, what we're doing to optimize the performance of the TAV-in-SAV procedure has been quite limited. We were initially just very happy to put a valve in. We didn't care too much about the position. We looked at the leak. We didn't worry about post-dilatation. We were just happy to get that valve in. And so then when you look at the data, you don't see the rates of post-dilatation balloon valve fracture to optimize hemodynamics down the track. And I think that's what's going to make the difference going forward if we're going to compete with redo SAV.
Yeah, okay, thank you. And I personally think that part of the reason is like a poor quality of initial server, Yeah. It's very important to discuss the details of procedure with the heart team. Okay, do you have any comment? Yeah?
You touched on a great point here. We've got surgeons here, and I'd love to find out from a surgical point of view, what is the responsibility of a surgeon in the index procedure for lifetime management? We always talk about the cardiologist and the TAVR lifetime management, but living coronary is this low, and we see it with mitral flow and trifecta a lot. But regarding CT sizing and coronaries, what do you guys?
Right, that's a great point to discuss. Shinichi, you want to answer?
Yeah, so I think nowadays in the TAVR era, if we just do isolated server without anything fancy, root enlargement, annular enlargement, or root replacement, TAVR is better. And then at least our cardiology doctors do not like it if we are just implanting 19, 20 millimeter valve without modifying anything, then we are not going to send any patients to you. Goodbye. That's the response we receive. TAVI is much better. So we have to do something better. And then what's better for surgery is, as Dr. Tabata mentioned briefly, we had to do a high quality server, which includes a good quality anatomy-oriented annular root enlargement or total root replacement if the coronary is really low, and then choose the high quality surgical prosthesis as well. That's also important because one of the mistakes we made back then when TAVR-SAVR trial was ongoing, more than 30% of the SAVR arm were containing those externally wrapping prosthesis. So ironically, SAVR arm promoted the TAVR arm significantly. And I know people hate to hear that, but I think that's the reality. And surgeons need to do a better job. That's my takeaway.
That's a very good point, Shinichi, because you have to know the team that you work with, right? So this is important also because sometimes people say, oh, this is a young patient, we're going to send to surgery. But what kind of surgery are you going to offer to that patient? Like in the US, we have a larger population, to be mild on my way of calling it. But, and therefore, we have to be able to know if my surgeon can do a root enlargement or can do, if a patient has a low coronary, that you have to set up that patient for success in the future, right? And that's true as well for the selection of the transcatheter valve we're going to use for our patients, right? We have to select the ideal device so we can set up the patient for success in the future. So that's why we have to know very well the team we're working with and make good choices as a team collectively.
Yeah, good point. Yeah, and I think a preoperative cardiac CT for all server candidates is a must. Yeah. Okay. All right, thank you. We are behind the schedule, so let's move on. Thank you, Brock. Okay, last speaker is Shinichi Fukuhara from Michigan, the US, and he's an expert of TAVR explant. Of course, he's an expert in any other cardiac surgery, but yeah, I'm very much looking forward to your talk. Okay, please.
Thank you so much, Dr. Tabata, for the introduction, and I'm just waiting for the slide to come up. But so let's talk about the TAVR explant, and then here are disclosures. So the role of TAVR explant is evolving significantly in the past few years. It used to be a bailout procedure, but now it's a planned, valid strategy. Here are reasons. One, TAVR first approach for young patients, such as like a patient who are in their 60s, is very common in the US. Redo TAVR is not necessarily feasible or suitable for everybody. Durability of redo TAVR remains unknown. And the TAVR explant clinical outcomes are remarkably improving, which I'm going to show you very shortly. So it used to be bailout procedure, and you can see this is a post-mortem setting. This is transapical explantation of embolized TAVR. That's really, exciting. But so it used to be those, bailout procedure. To wake everybody up, I will show you some exciting case. This is also bailout procedure. So this patient had a previous CABG bilateral internal mammary artery patent, and the TAVR valve flipped, and went into the left subclavian artery where lima is coming off. So patient became unstable. I had to open. The patient has bilateral IMA. Right internal mammary artery is crossing the front. But, so we just expanded the TAVR, and there was an intimate here. This is one of those bailout procedures, but this type of scenario is seen less and less. Let's talk about some TAVR reintervention volume forecast. We love this type of forecast, and we talk about this based on our assumption. But I want to just show you something. So if we just zoom 2020 to 2024, so this is actually this is a forecast of TAVR expand volume, and this is what happened in the 4 years. Look at this. This forecast miserably failed. So let's take a look at the redo TAVR. Again, forecast redo TAVR volume 2023 is here, but this is the actual redo TAVR volume that's counted based on the TVT or Medicare data. So yeah, we always talk about the forecast, but the reality is different. So this is a Medicare data so one thing I want to emphasize. So green, redo TAVR, blue, TAVR expand volume. These are increasing steadily at a similar pace. And if we look at the STS TAVR expand volume, it's actually here. So, and then this is a reality. If we look at the patients who received the TAVR valve at the age of between 65 and 70, more than 50% of patients ended up having TAVR explant. So this is a reality. So TAVR explant may be necessary in 50% or more than 50% of post-TAVR patients. How about outcomes? This is a very new data that was just presented a couple of weeks ago. So this is based on the updated STS database, 5,700 TAVR explant data. And then this is just a subset of the group, basically isolated the SAVR after TAVR, after excluding endocarditis urgent emergent cases. So this is a counterpart of a redo TAVR procedure, I would say. So this represents 40% of the entire cohort. Look at the operative mortality in the past 2 years, 3.5%. There's a caveat I will emphasize, all-comer mortality is still very high, but if we look at the counterpart of a redo TAVR population, it's 3.5%. So I'm just reminding you, this is the TVT registry data for redo TAVR. 30-day mortality was 4.7%. So 30-day mortality, redo TAVR is 4.7% versus selected TAVR explant is 3.5%. This is what's happening. So TAVR explant is transforming from a rare life-saving salvage procedure to a valid post-TAVR reintervention option. Look at the Medicare data, long-term results. So TAVR explant yields a favorable long-term outcomes. Yes, this is a red. Initially, TAVR explants are having higher mortality. However, the survival curve crosses, and then long-term, it's more favorable. Risk of TAVR explant, initially really high hazard ratio, but it crosses, and at the 7-month hazard ratio of TAVR explant is statistically lower compared with the redo TAVR group. And this is a doubly robust estimation, propensity score matching plus Cox non-proportional regression. This is already adjusted groups comparing. So this is one of the very first my TAVR explant case, and the 87-year-old female, 87, patient had a SAPIEN 5 years prior, and then at that time, I was just a new attending. I didn't know anything about this. I didn't know anything. I had no insight. And then I saw this. Oh my God, how do I get this out? And then patient was already very sick. So patient needed ECMO. Chest was left open. Again, patient was 87-year-old. But she survived. She's doing very well. I just saw her. This is from the medical record. She's 94. She's becoming 95 very soon. I suggested to her to stop driving because I heard that she was still driving, but she's still doing very well. This is a power of TAVR explant. Once patients do well, longer term, it's very favorable. So this is our practice at the University of Michigan. So we performed the TAVR explant 181 cases at the end of 2025. Median age is as listed. 60% of patients received the TAVR outside and they came to see us at the time of TAVR explant. And then about 87% patients received either aortic repair or root enlargement. So again, just a straightforward SAVR procedure is very rare in our practice, and the 17% are endocarditis. So if we look at just our own TAVR patients, considering the denominator index TAVRs, actually, and we performed the redo TAVR 63 cases. So TAVR exam versus redo TAVR ratio is almost 1-to-1. So this is 50% patients needed TAVR explant. And this is probably true. So look at the TAVR explant. This is all comers, not the isolated SAVR. All comers in 2025, we performed the 54 TAVR explant, and our mortality came down to under 2%. So this is one of our recent patients, 75-year-old female severe AS for a 26mm Evolut Pro. She had an uneventful TAVR procedure, and she developed a halt. Despite the warfarin, she developed a severe AS. STS PROM, despite the age of 75, was still 2.4. So we ran DASI to see if redo TAVR is feasible. According to DASI, yes. If we put the 23mm SAPIEN inside this TAVR valve, node 5, inflow to inflow, yes, it's feasible. Then this is a question. Would you treat this patient with redo TAVR versus TAVR explant? She's still low risk, but small body size. Reasonable redo TAVR anatomy, but small prosthesis. And then what we chose was explant. Even though she had a reasonable redo TAVR anatomy, this is what we do. And then this is just one of the cases. I'm standing on the left side with the camera. Our residents is standing on the right side. She saw perforated aorta from the strut, and she started freaking out. And then I was just calming her down. Don't worry. And then, I started making aortotomy, and then basically for Evolut explant, I just make aortotomy right at the distal end of the stent frame, and I simply included this perforated aorta along the aortotomy, yes? And this is all you need to do. And then when we perform Evolut explant, I basically transect the aorta completely, then visualization is much better. So I'm just validating what the DASI told us. So left coronary may be okay, but if we look at the right coronary, I'm just simulating redo TAVR. Maybe this wasn't the okay case for redo TAVR. Anyway, I think we chose the right decision regardless in retrospect. And then, I think many of us have some prejudice that short frame TAVR valve is much easier to explant. Tall frame TAVR valve is much more difficult to explant. And then that's actually not true. We have performed approximately 100 tall frame TAVR explant. And then there's no major difference. And I will show you some objective data too at the end. But so again, patient's surgical valve size is 21, but we performed the root enlargement and implanted 25 millimeter valve. Post-op course, she did very well. So we had to think about not only the survival, but also we had to think about the lifetime survival optimization. So we should offer a high-performing durable valve as the first valve. And we should minimize mortality or disability. I want to emphasize this. Offer a durable reintervention option with a low mortality or disability risk. And we should minimize the number of reinterventions. So how can we minimize the total procedural mortality or disability across the lifetime pathway? So let's think about this. So this is a post-TAVR reintervention rate at the 10 years. Actually, the reintervention rate is surprisingly low. Only 2.3% of patients actually needed the reintervention. This is a Medicare population based on the 400,000 post-TAVR patients. So TAVR durability is indeed very good. And then reintervention necessity remains a very, very small subset as of today. And then let's think about the TAVR first approach. So if we perform a SAVR and then subsequent TAVR, we just talk about this TAV-in-SAV approach may not be as durable. There is actually a signal from a number of data that this may not be as durable. And there are probably reasons maybe SAVR procedure was not as good. So if we perform TAVR first, so it can be TAVR followed by TAV-in-TAV or TAVR followed by TAVR explant. So if we perform TAVR first and then followed by TAVR explant, this may yield the best outcomes if TAVR explant is safe, because the number of reinterventions may be the lowest for the 20-year span. Durability from a single reintervention procedure, this may be the best. And then enhancement of survival without a disability by having a chance of redo TAVR option if patient has a really reasonable redo TAVR anatomy. So as a surgeon, I actually advocate TAVR first approach because the TAVR explant procedures are becoming very safe. So TAVR first approach for young low-risk patients, yes, we should make the procedure perfect, and we should use excellent valve, and then in terms of performance, good durability, and the reliable commissural alignment. So we have to choose the right TAVR valve, and then I strongly advocate Evolut FX Plus. This is meeting all the criteria for this. So lastly, let me talk about tall frame TAVR versus short frame TAVR explant. This is to be presented in May at the AATS, but we have been recording the objective score for TAVR explant difficulty since the 19th case of a TAVR explant. So we have a good data. This is objective data that there is no difference between short frame TAVR versus tall frame TAVR in terms of difficulty. So what's different is if that's a TAV-in-SAV and explant, it's very easy compared to the TAVI inside a native aortic valve. It's more difficult. This is what dictates the difficulty. In summary, so TAVR-first approach for young, low-risk patients may be a valid, attractive, durable option in selected patients. And they use the vessel TAVR valve as an index TAVR, such as Evolut FX+. And then consider TAVR explant if no redo TAVR option. And the TAVR explant outcomes are dramatically improving, and it's even comparable to redo TAVR short term, and associated with favorable long-term outcomes. Thank you so much for your attention.
Thank you. It's a great talk. I think everybody learns a lot from you. Especially a remarkable improvement in TAVR explant over time is very impressive. I think your contribution to standardization of the procedure is significant. Actually, before I hear your talk, I had a TAVR first approach in the 60s. And those in the 60s in the US was completely beyond my understanding. But yeah, after hearing your opinion, my thought has changed. But I have one question. So if the patient requires one-time open heart surgery during their lifetime, most of them prefer not to have that in the late 80s or 90s, like your first patient did. So I was wondering whether we should be more cautious about performing TAVR in a 75-year-old patient rather than a 65-year-old patient. What do you think about that?
Yeah, that's a great question, and then nobody knows the answer. And then, but I think we have to remember. People who are talking on the podium are people who are always performing, aortic root enlargement routinely. Myself perform 85% of a SAVR procedure is with a root enlargement. But the majority, if we look at the society level database, SAVR with root enlargement is a significantly higher risk in terms of mortality. So the majority of surgeons still perform just isolated SAVR procedure, implant a small valve, and then, and then some of them are anti-root enlargement. Okay, so in this setting, we cannot ask all the surgeons to perform a high-quality SAVR procedure with root enlargement. In this setting, as I mentioned, comment, I think the TAVR first approach is better. And then, if we are able to perform TAVR explant safely, I think that's also good. And the TAVR explant, we can just do the SAVR procedure without the root enlargement. That's, I think, acceptable. But yes, if patient becomes 80s, 85, that's the tricky part. So if patient receive a TAVR at the age of 65 and they needing explant 75, that's probably a good option. We have to be cautious when we perform a TAVR around a 75 to 80-year-old patient, particularly someone without redo TAVR anatomy, obviously, at the time of index TAVR.
All right, thank you. So I want to ask a cardiologist's opinion about lifetime management, including a TAVR explant. In the US, I heard TAVR rate in the 60s has been decreasing gradually in the recent years. Is that true in your practice? Or, yeah.
Well, we don't use the age cutoff. I think, as Shinichi mentioned, it's always important to individualize the discussion. Right? So the age cutoff is obviously something we take into account, but also, if these patients normally, if they're 60 or younger, a lot of these patients they have bicuspid valves and dilated aortas. These patients certainly we're going to favor surgery until proven otherwise, right? So we have to also use common sense in terms of deciding what therapy we're going to offer to that patient. In addition, and I know that in my team, like Shinichi mentioned, I mean, if I'm going to send a patient to surgery, they're going to, if it's a small root, they're going to perform root enlargement and put a big valve and set up the patient for success in the future. So in our practice, we take that into account. So I know that if I send a younger patient to surgery, I know the patient is going to get the best possible valve and setting the patient up for success. So we don't use the age cutoff as a single metric, but rather we use that as one of the metrics and then decide collective discussion on what's the best therapy for long-term management.
Makes sense. Right. And do you agree with the TAVR first approach, including a future TAVR explant, like Shinichi suggested?
Well, I think we cannot prove that that's the best strategy, but I think showing that the outcomes of a TAVR explant are progressively getting better, right? Certainly, we're going to have to take that into consideration now in terms of the decision-making process, what comes first for each patient.
Okay, all right, thank you. Do you want to make some comment?
Yeah, so I mean, we're seeing younger and younger patients being treated with bioprosthetic valves, both TAVI and SAV, and I guess one of the issues is with the morbidity from SAVA. Let's say your first procedure is a SAVA, you're in your 50s, and for whatever reason you haven't got a mechanical valve, you've got a bioprosthetic valve. If the patient's suitable, you do a mini AVR, avoid the sternotomy, and so you're setting that patient up for being able to then do a TAV-in-SAV, followed by an explant of a TAV-in-SAV with the first sternotomy, which to me would seem like a very good way to get 4 decades worth of use out of combinations of surgery with one sternotomy and TAVI procedures. Do you do much mini procedures to preserve the sternum?
Yes, I do mini procedure as well. And then one of the probably benefits of a mini procedure, although it's very hard to prove objectively, is ease of redo surgery. And then, I mean, at least at the University of Michigan, virgin chest SAVR versus redo SAVR, there's no difference in terms of mortality. And then the redo SAVR patients do very, very well. So yes, if we can do SAVR, mini AVR, followed by redo SAVR, yes, that's a great approach. But again, if we go back to just to the entire society level, how many surgeons feel comfortable performing those procedures? That's a question. So those procedures are not necessarily available for everybody.
All right, great. Thank you, Shinichi. Yeah. So we have now reached the end of a session. As we know, the Evolut platform offers a very excellent durability and hemodynamics. But to maximize that potential of the device, we need to know both precise and safe implant technique and management of the reinterventions. So today we learned deeply about optimizing our procedures, specifically regarding transcarotid access and use of ice and pacing strategies. And we also tackled complex decisions regarding TAV-in-SAV and TAVI explant, which really is important for lifetime management. So I think today's discussion highlighted the actual necessity of a heart team approach for all aspects of a heart valve management. So, and then in the end, I'd like to thank all speakers, discussant, and Medtronic for making this meaningful discussion possible. And thank you all for joining us. All right, thank you.